You roll up in an ICU room and you see a patient that is intubated, mechanically ventilated. And here I'm utilizing a test lung, but nonetheless a roll up, and I see these ventilator graphics. Things that jump out at me right away. Plateau pressure is being shown with every breath. So we've got that plateau. So there's some type of inspiratory hold, inspiratory pause that's implemented on every breath. Should there be? Probably not. There are some reasons why you would do it if you're trying to increase someone's mean airway pressure, improve their oxygenation, or what have you. But for all intents and purposes, none of us take a breath in, hold it for a little bit, and then let it go. So we need to fix that. Also take a peek down here at the volume flow waveform and see that my volume's not necessarily making all the way to baseline before the next breath begins. And I can also see that that volume is being held for however long that inspiratory pause or time pause is put in on this breath. So this lets me know I've got a leak somewhere within the system. This lets me know that somebody didn't know to turn off that. If I look through the chart and find that there's no reason why this patient's got a whatever amount of time that is pause, then somebody just didn't know to turn it off. Look at our control, so we're in volume control ventilation, tidal volume of 450, respiratory rate of 15, PEEP of 5. We're ventilating right now at 21% because I'm in the lab and don't want to use excess oxygen. Inspiratory time of 0.4, and there it is right there, the T pause. This machine defaulted to 0.40 T pause. That should be taken down to 0. I'm not, like I said, I'm not saying that's an always scenario, because there are some individuals that could benefit from that pause if you're trying to improve their oxygenation. But naturally, for someone that you're just trying to make synchronous with the ventilator and so forth, it's not natural for us to take a breath in, hold it, and then let it out. Also, when looking at these settings, look at that pressure trigger. That pressure trigger is -6. We've probably locked this patient out from being able to trigger any breaths. So make sure you're attentive to your patient trigger as well, whether it's a flow or pressure trigger. And then now, one other thing to take a peek at. So I turned the 0.4 second pause off, and we'll notice that our pressure waveform looks much better. So now I've got to try to figure out what's going on with where the leak is. If the leak is not, if you have a ventilator alarm or there's a problem with the alarm and it's not immediately apparent, you should disconnect, manually ventilate, ensure that the patient's ventilating before you spend X amount of time troubleshooting. In this case, I can absolutely hear already with this suction catheter where the, and I can feel it. So for instance, if I plug that port there and I'll show back at those ventilator graphics, we can see that we no longer have a leak. We can also see that expiratory tidal volume increased just a little bit from where we were at as well. So what happened here, there's a port that's supposed to go on, and that's the port that you can instill saline. This port has some inadvertently, whether through turning a patient, what have you, it got pulled off of the ventilator circuit. So we got to make sure that we pay attention to what's going on. You know, not to say that we should not ever really worry about treating the monitor, but treating the patient. But there is information from the monitor that can let us know why our patient may be looking to be asynchronous with what's going on. Thank you all for your time.